Okay, class, and today I'm going to go over the Chapter 8 PowerPoint within the book, which is now going over the endocrine system. So thus far within Module 1, we have gone over Chapter 1, Chapter 2.2, and now we're going to go over Chapter 8 to finish up the module. So Chapter 1 was devoted to the structure of certain body systems and the anatomy of body systems, going over those big directional terms. Chapter 2 was devoted toward cellular structure and organelle function and structure. And now we're going to make kind of a big shift over to the endocrine system, going all the way to hormone function, different glands, receptors, and a good bit of anatomy within that particular system. And keep in mind that the endocrine system, Chapter 8, is going to be on quiz number 2. Quiz number 1 was on Chapter 1 and Chapter 2. Quiz number 2 is going to be specifically on Chapter 8. It's kind of a robust PowerPoint, but I'll try to make it as concise as possible. So hopefully everybody can see my screen. And like I said, this is the endocrine system. And the primary objectives of this chapter is I want to make sure that you understand the big components of the endocrine system, understanding that HPA axis, the hypothalamus, the pituitary, the adrenals, making sure that we understand the role of the pancreas, insulin, glucagon, the role of the ovaries and the testes, and also discussing a little bit of the pineal gland. And that's how we get a lot of our major classifications of the hormones. We have our steroid hormones that are produced by the HPA axis. We have the pineal gland that produces calcitonin and melatonin. And then finally, we have some of those, again, hormones produced by the pancreas. They're going to be involved in a lot of metabolism, still considered some of those anabolic hormones, but also discussing catabolic hormones as well. So make sure that we understand that we have a gland, we have the hormone being produced, and then we have the target tissue, and then some of the outcomes associated with that. All right, make sure within the overview, you do take some time to understand some of these word roots and combining forms. It can be a little bit difficult to remember all of the hormones that I'm about to go over, but if you remember some of these prefixes and suffixes, then you can kind of put it together. For example, cortico, or cortic, that is referring to the cortex. If we see andro, then that's referring to male. If we see gluco, that's referring to sugar. And the list goes on. I'd say the big ones that you need to understand are, of course, gonad, steroid, and then the thyroid, the thyro. Those are your big word roots that can help you piece together what some of these terms are referring to. And if you know the suffix, then depending on the definition of the suffix, then you can piece together what the hormone does. Okay, but like I said, big overview. The main things that you need to know within the endocrine system is you need to know all of the glands and all of those major organs that are responsible for the hormone production. So as you can see with the big overlay, the major organs of the endocrine system is the pineal gland. That's that melatonin and calcitonin production. It's the hypothalamus. That's all the way at the top of the brain. The pituitary gland, one step down. The thyroid glands, another step down. Then we have the adrenals, the pancreas, the testes, and then the ovaries. If it's the HPAT axis, you know that those are our anabolic hormones. Hypothalamus, pituitary, adrenals, testes, and ovaries, and we work our way down. So we always start at the very top with the hypothalamus. The hypothalamus initiates a number of processes, and then again, we can work our way down to some of those sex organ components of the endocrine system. Okay. But ultimately, what's the purpose of a hormone? The purpose of the hormone is to communicate with the target tissue. It's one of our main communication systems. We have two big communication systems in the body. That's the nervous system and that's the endocrine system. The nervous system communicates through neural impulse and neurotransmitters, and the endocrine system communicates through hormones. At the end of the day, it is a communication system, and we're trying to get an outcome from that target tissue. Okay, so like I said, communication of the nervous system and the endocrine system, they work very similarly. If you understand the nervous system a little bit better, then think about that. We have a neural impulse that drives down the tissue or drives down the pathway. In this case, it is a nerve. And then once we get to the end of that neuron, released out of the end of the neuron, which is the axon terminal, that's when we have the release of the neurotransmitter. The neurotransmitter will then bind to the target cell, and then we have the desired outcome. It is the exact same way as the endocrine system functioning. The endocrine cells within the gland or wherever they happen to be, they produce a type of impulse. They produce a messenger or a hormone. They produce a couple of things, but they produce the hormone. It travels down the blood vessel. Sometimes it's released into the blood. Sometimes it communicates directly with the nervous system, actually. But most of the time, it travels into the bloodstream, travels down the blood vessel, continues to the target cell, and then we have the desired outcome. So ultimately, it is a communication method, okay? In the anatomy of the endocrine system, a gland may be a separate structure all on its own, or it may be groups of cells, right? It can be a standalone unit, or it can be a part of a greater group. Either one is true, but the typical hierarchy in all the major components of the endocrine system, once again, is the endocrine gland, the hormone that was produced, and then the target tissue. Okay, so here is a little bit more of a close-up. Here are all the major endocrine system glands that you need to be familiar with. All the way at the top is where we have the beginning of most of those communication methods. All the way up at the hypothalamus, that's where a number of things start. And what you'll notice is the hypothalamus works downward, and it communicates with gland, to another gland, to another gland, and then we finally get down to the target tissue. So the hypothalamus at the top, right next to it is the pineal gland, okay? And the hypothalamus, again, right below that is the pituitary gland. The hypothalamus communicates very closely with the pituitary gland. The pituitary gland has two parts, anterior and posterior. Anterior, for whatever reason, does a lot more than the posterior. The anterior pituitary gland releases 8 total hormones. I think we talk about 4. But in any case, the pituitary gland does a lot of things. Sometimes the pituitary will communicate with the adrenal gland. Sometimes it'll communicate with the thyroid. Sometimes it'll communicate with the parathyroid. But in any case, we're continuing to work our way down. Now we're at the thyroid gland, which is right at the bottom of the neck, right? And then we communicate further downward. The adrenal glands are right on top of the kidneys, right? And the adrenal glands are responsible for epinephrine and norepinephrine and cortisol. And then we also have the pancreas, which of course the pancreas produces that insulin and that glucagon, very important for blood sugar control. And that's the site of diabetes if there is an insulin resistance or some type of blood sugar issue. And then finally, we go all the way down to those reproductive sex organs, ovaries and testicles, and that's where we have our big production of our 2 major sex hormones, estrogen and testosterone, right? So that's the I don't want to say hierarchy, but that's how it works its way down. If you ever struggle, remember the term HPAT axis, and it's an axis because it typically works down or up, one or the other, right? But we start at the hypothalamus, work our way down, and sometimes we loop our way back up. But in any case, we're typically following that path. Okay. All right. So glands, a couple of more things that you need to be familiar with. The pineal gland function is not completely known. Why is the function of the pineal gland not well understood? Because the circadian rhythm tends to be more of an influence in terms of the master biological rhythm there rather than hormone function, right? So typically hormones, they function independently based on the need of the body, based on, maintaining homeostasis or maintaining some type of feedback loop. That's how most hormones function, and it's on a wave throughout the day and throughout the night, and we just have a natural rhythm there. The pineal gland is not well understood because it produces melatonin and calcitonin, but melatonin is produced more so in response to circadian rhythm, not toward an independent biological rhythm. So hopefully that makes sense. But in any case, all hormones have a biological rhythm that they function on, right? So a great example is testosterone. Testosterone in men tends to be highest at 9 a.m., right when you wake up, right? And as the day goes on, as you experience some stressors, as you eat high carbohydrate meals, as you exert yourself, whatever, throughout the day, there tends to be about a 30% drop in your testosterone production. So that's a classic example of one of those rhythms. In the morning starts out very high, and then it kind of works its way down, and then you sleep, and now it's very high again, and then up and down we go. So that's a biological rhythm. Has a lot to do with lifestyle, has a lot to do with your age and your body composition and a number of other things. But most hormones are produced and also are reduced on a rhythm, on a pattern. Okay. All right. So let's start with the hypothalamus and the pituitary gland. These are huge glands that produce a lot of things. First, the pituitary gland, like I said, has two parts, anterior and posterior. Nothing too complex there. Just remember that the anterior pituitary gland produces a good bit more than posterior, of course, equally important, but just remember that they're not exactly the same. The hypothalamus plays a major role as a gateway for the brain to control the endocrine system. So the hypothalamus is like our thermostat. It's like our master control panel. The hypothalamus initiates the production and it stimulates a number of glands, and it gets the ball rolling. It gets the process started, right? So the hypothalamus is connected to the pituitary gland's two parts by stalk called the infundibulum. I haven't said that in a while. Infundibulum. Okay. I'll look up the pronunciation of that. But in any case, there is a direct communication between the two. Hypothalamus and pituitary, it's connected by a stem or a stalk, and I will try it one more time. Infundibulum. Infundibulum. All right. So there is a direct communication there. Why are they so closely connected? Well, the hypothalamus, for example, produces thyroid releasing hormone that will communicate directly with the anterior pituitary gland, which will then produce thyroid stimulating hormone, which will then communicate with the thyroid gland, which will then produce thyroxine, right? So the hypothalamus tells the pituitary who to communicate with, and it's a very vast process, right? But there is a direct connection there. Remember that term, right? And then this is a great picture. This is the method by which the hypothalamus gets everything started. So the hypothalamus can produce one of four hormones. We have growth hormone releasing hormone, thyrotropin releasing hormone, corticotropin releasing hormone, and gonadotropin releasing hormone. So what do all of those hormones have in common? Released by the hypothalamus. They all have in common the word releasing. Okay, so the hypothalamus, it's interesting. It's not the one directly producing the hormone that's responsible for the action. The hypothalamus is the one telling the gland to produce the hormone that's taking the action. The hypothalamus is the one giving the instructions, and the pituitary gland, anterior pituitary gland, more often than not, is the one actually releasing the hormone or stimulating the release of the hormone, right? So the hypothalamus is the drill master. It's the one giving all of the instructions. We communicate one of those four hormones with the anterior pituitary gland, and look at what the anterior pituitary gland is responsible for producing. Growth hormone. That is huge. It communicates with bone, muscle, adipose tissue, growth and initiation of protein synthesis, and a number of other things. It produces thyroid stimulating hormone. Of course, that communicates directly with the thyroid to produce that thyroxine. It also produces adrenocorticotropic hormone. I know that's a big mouthful, but that's communicating directly with the adrenals. And the adrenals are where we get our cortisol production, epinephrine and norepinephrine. And then over here on the right, these are our two big steroid hormones or steroid releasing hormones, luteinizing hormone and follicle stimulating hormone. Okay. Luteinizing hormone and follicle stimulating hormone are very similar. Those are our two primary gonadotropins. If it's a gonadotropin, that means it communicates directly with the gonads, right? So luteinizing hormone is going to stimulate the testicles. Follicle stimulating hormone is going to stimulate the testicles or the ovaries, right? So we have all of these major hormones that are producing or responsible for the stimulation or the production of something. More often than not, it's a steroid hormone, as it's a big part of that HPA axis. All right, so do know the anatomical features and the anatomical location of the hypothalamus and the pituitary gland. The hypothalamus, right, is right here at the kind of centralized point of the brain. It's right above the midbrain. And what you'll see is that stalk that works its way down, and now we have that anterior lobe, okay? The anterior lobe, of course, toward the anterior portion of the brain or the body, right? Anterior portion is up here at the front, posterior is at the back, closer to the pons, this big, grayish area back here. That is the pons, right? So if you're trying to remember where everything is, hypothalamus is more toward the top of the brain, right in the central component, just above the midbrain. Work our way down just a little bit, and then we have the pituitary gland that's connected by that stalk, right? Now, what's housing the pituitary gland? The skull has a very specialized bony structure. It's called the sella turcica, and the sella turcica has one job, and that's to create a little chamber for the anterior and posterior pituitary gland. Sits in there very nicely, and then it's not only protecting the pituitary gland, but it serves as a little housing space, right? So that's your gross anatomy of hypothalamus and pituitary gland. And when we take a little bit of a closer look, all of this is saying is that we just have that direct line of communication. Hypothalamus and pituitary gland, they are best friends. They have one primary pathway that it travels down directly into that pituitary, and then it can release whatever hormone it needs to. Okay. All right. So that's hypothalamus and pituitary gland. Let's shift gears toward the thyroid hormones and the thyroid gland now. So we've continued to work our way down, and now we have another big gland and another big class of hormones that we need to discuss, and those are our thyroid hormones. Thyroid hormones are most classically known for regulating their metabolic rate, but they also are known for protein synthesis and neuron function as well. So critically important hormones, right? The pituitary gland releases that thyroid stimulating hormone. It'll communicate downward, and then it'll stimulate from the thyroid gland to release one of two thyroid hormones, and that's T3 and that's T4. And the T4 is that thyroxine, right? So what's the role of the thyroid hormones and what's the role of the thyroid gland? Like I said, metabolic rate is the big one. It's the one responsible for that caloric breakdown, substrate breakdown into usable energy, into that ATP form. A lot of big stimulatory processes there. And keep in mind, this is one of our initiations or causality of disease that I want you to be familiar with. If you have a dysfunctional thyroid gland, that could be hypothyroidism, known as Hashimoto's, or we could have a dysfunctional thyroid gland, which results in a goiter, which is that, swollen portion of the neck. That is caused by iodine insufficiency, or you are deficient of iodine, right? So if you don't have enough iodine, then the thyroid gland does not function properly. What's our number one source of iodine in our diet? That is salt, believe it or not. Iodine is very hard to come by in your diet. I think iodine naturally occurs in seaweed or something to that effect, but fortified salt is our main source of iodine, and it's called ionized salt, meaning that they put iodine in it, right? So iodine's very hard to come by, but it's been fortified in salt, and we don't have any problems consuming salt typically. So thyroid gland typically works just fine because there's sufficient iodine, and then we get plenty of that T3 and T4 production. Okay. What else does the thyroid gland produce? It also produces calcitonin. So calcitonin, that should be a pretty easy one because the function of calcitonin is kind of in the name. It's responsible for lowering blood calcium that is in the blood. Calcitonin removes some of that calcium. So remember, calcium, calcitonin, it's in the name a good bit, right? So lowering blood calcium by stimulating calcium deposition by osteoblasts in the bone, right? So if calcium remains in the blood for whatever reason, that can cause a number of problems. The first thing that comes to mind is it's very damaging to the kidneys. If we try to excrete calcium through urine or whatever, if there's calcium in your urine, that's usually a big sign of osteoporosis, and it can cause kidney stones and a number of problems. But if we have sufficient amount of calcitonin, that calcium gets redeposited back into the bone through osteoblast activity, and then we maintain bone density, right? So that's the main role of calcitonin. It's maintaining bone density, and it's recirculating calcium back into the bone. Okay. Now, the thyroid also has a subcomplex, which is known as the parathyroid gland, and the parathyroid gland produces a very specific hormone. It's common sense, the parathyroid hormone. Now, what does the parathyroid hormone do? It does the exact opposite that calcitonin does. So calcitonin removes calcium from the blood. Parathyroid hormone increases the concentration of calcium in the blood, or it puts calcium back into the blood. Now, it can do this a number of ways. It promotes calcium removal from the bone by osteoclast activity. It inhibits the excretion of calcium, or it promotes calcium absorption in the blood by the intestine. Now, you're probably wondering, why on earth would we want to have calcium in the blood as opposed to calcium remaining in the bone? Well, the remodeling process of bone takes place on a moment-to-moment basis. Anytime we need to remove portion of the bone, that could be through damage, that could be just from a normal remodeling process. Whatever the case is, osteoclasts are always removing portions of bone in order to make way for formation of new bone. Every time there's increased osteoclast activity, that calcium deposit and that bone salt that's being removed from the bone, it has to go somewhere. We have to do something with it. Parathyroid hormone will take that calcium that was being removed from osteoclast activity, put it back into the blood, and then it can be excreted later, or it can go somewhere. It can be redeposited elsewhere. There's a couple of destinations that could happen, but that's the whole role of parathyroid hormone. It's going to take that calcium from the bone back into the bloodstream. We can maintain some of that calcium, keep it in the bloodstream by not excreting it through the kidneys, or it could promote calcium absorption through the intestines. So in any case, parathyroid hormone does the exact opposite that calcitonin does. So parathyroid hormone, or the parathyroid gland, in a way, is the exact opposite of the thyroid gland. They directly counteract each other. Okay, and here's a quick picture of it. Right below the larynx, right? So you have the trachea, right? As we work our way down the neck, that's where we have the thyroid and the parathyroid. If you're given a picture on the quiz, just remember we start at the top, hypothalamus, pituitary, and now we're down to the thyroid, which is toward the bottom of the neck. All right, continuing to work our way down. Now we're at the pancreas, okay? And the pancreas does a critically important job, which is maintaining blood sugar levels. If we have low blood sugar, then we need to increase it. If we have high blood sugar, we need to reduce it. And why is managing blood sugar so important? Because blood sugar is one of our primary sources of energy, right? We have to have blood sugar in order to sustain energy production, and sugar, it just plays a number of roles, right? So, because we need to maintain blood sugar on a moment to moment basis, the pancreas functioning is very important. And what does the pancreas produce? What does the pancreas gland produce? Insulin and glucagon. And just like calcitonin versus parathyroid, insulin and glucagon do exact opposite things. So first, what does insulin do? Insulin is responsible for taking the sugar that is in blood and shuttling it into the target cell. The target cell could be a number of things, but it takes the blood sugar and it removes the sugar from the blood. So if that's what insulin does and glucagon does the exact opposite, what does glucagon do? Glucagon is going to take sugar that was stored in the cell and put it into the blood. So it raises blood sugar, right? So we have two hormones doing exact opposite things, and we are managing blood sugar on a literal moment-to-moment basis, operating by that biological rhythm. And managing blood sugar is very important because it's maintaining energy levels, right? And this is one of our major metabolic diseases that we need to be familiar with. Type 1 diabetes and type 2 diabetes, if we have chronically elevated blood sugar, if we have inability to manage blood sugar, that means we're becoming insulin resistant, blood sugar getting too high because there's not enough insulin removing the sugar from the blood. So we'll talk about that more here in a minute. Okay. But what is the pancreas responsible for? Producing insulin and glucagon, but it also secretes digestive enzyme, and this is all carried by the pancreatic duct in the small intestines. So the pancreas and the small intestines communicate very closely with each other. What is the highway in which the two are connected? In terms of exocrine functioning, the pancreatic duct. Okay, so it's underlined, so make sure that you're familiar with it. And here's it all put together. So what you see, the green structure is the gallbladder, right? But we have this elongated organ right here, right in the center. That's our pancreas, okay? And this tube right next to it is our small intestines, and this is where we have our connection. This is where we have our communication, right? So we have, if you zoom in, we have in the pancreas, we have the duct itself, we have the digestive enzymes being produced, we have the islets or the Langerhans islets, which is where we're having a lot of that hormone production taking place, pancreatic islets, and then finally the capillaries, or the blood vessels that are actually carrying the hormone. So make sure that you're familiar with some of the anatomical features. The big one right here is those pancreatic islets, or the islet of Langerhans, right? So I know that sounds like a strange term, but Langerhans, islets of Langerhans, why is that important? That's where we get a lot of our hormone production from. Okay. All right. So that was the pancreas. Relatively simple. Now let's talk about the adrenals. Okay, adrenals, very important. The adrenals are right above the kidneys, right? So we haven't deviated too far away from the pancreas, right? So the adrenals, we have two adrenal glands, one at the top of each kidney, and the adrenal glands consist of two portions. Okay, we have the inner portion of the adrenal, and of course the outer portion of the adrenal. Inner portion is the adrenal medulla, and the outer portion is called the adrenal cortex, right? So I don't really have any tricks on how to memorize that, but you've just got to remember the two. Internal is medulla, external is the cortex, okay? All right. So what does the adrenal cortex do, and what does the adrenal medulla do? So I'm going to start with the adrenal medulla, actually, because that one's a little bit more important in my opinion. The adrenal medulla is where we get a lot of that sympathetic nervous system functioning, right? So it's going to release hormones that directly communicate with the sympathetic nervous system. What does the sympathetic nervous system do? It's going to give you some of that more stimulatory hormones, right? And that's where we get our epinephrine and our norepinephrine, right? And epinephrine and norepinephrine, they're responsible for a number of things, but think about it as those stimulatory features, increasing heart rate, increasing respiration, increasing, glucose utilization. That's where we get a lot of our, fighting physiology from. We need to be elevated, we need to be stimulated, and that happens from epinephrine and norepinephrine sympathetic nervous system functioning. Okay. The adrenal cortex, on the other hand, this is where we get our glucocorticoids, some of our androgens, and some of our mineral corticoids. So it produces over 25 different hormones classified in 3 major categories. Again, remember those mineral corticoids, glucocorticoids, and our androgens. Androgens are typically some type of, androgenic hormones, usually stimulating the production of a steroid hormone or increasing the rate of protein synthesis or amino acid formation. That's what androgens typically do. But our glucocorticoids and our mineral corticoids, the main one you need to know is cortisol. Okay, so our adrenal cortex is where we get that cortisol production, and that is responsible for managing inflammation. It's called a stress hormone. It's a hormone in response to stress. It's not a hormone that produces stress, right? And cortisol, again, the main function of cortisol is to manage inflammation. All right, so here's a picture of the adrenal medulla and the adrenal cortex. That outer layering is the cortex, and the inner layering is the medulla. Okay. All right, and jumping right into the gonads. So now we're all the way down at the bottom. We're at the bottom of the HPA axis, right? What do the gonads, both female and male, produce? They produce those sex hormones and those steroid hormones. What are our main sex hormones? Estrogen and testosterone. Of course, the testicles will produce significant amounts of testosterone, and the ovaries will produce significant amounts of estrogen and progesterone, right? So we're all the way down at the gonads now. We've traveled all the way down to the bottom. Okay, and other tissues that you do need to be familiar with. The heart has, some atrial natriuretic hormone that's sometimes responsible for maintaining the depolarization rate and some of the cardiac rhythm. And the digestive system does have several hormones as well. So don't discount that the endocrine system is not limited to the HPA axis, the thyroid, and the gonads. There are some endocrine glands and other systems as well. Okay. All right. So now that we are down to the gonads, let's talk about what steroid hormones are and what do they do, right? So steroid hormones are almost always derived from cholesterol. So cholesterol is naturally produced by the liver. Of course, you can get dietary cholesterol, but typically the liver produces enough cholesterol in order to maintain steroid hormone production, right? We don't need a ton of dietary cholesterol. The liver produces it, right? And how do you know that cholesterol produces or is derived into steroid hormone? You see one of our suffixes that we talked about, sterol. What does sterol mean? It means steroid, right? So steroid hormones are derived from cholesterol, right? Okay, an example, like we've been saying, is estrogen and testosterone. And typically, what are the responsibilities of steroid hormones? They do a lot of things, but they're heavily responsible for the maturation process, progression of puberty, sex characteristics, external viralization, a number of things, but they are also responsible for maintaining rates of protein synthesis, right? So testosterone is heavily correlated with muscularity, right? That's a sex characteristic to an extent, but it's also heavily involved in protein synthesis and therefore muscle growth. So steroid hormones are, largely involved in muscle hypertrophy, protein synthesis, and therefore muscle recovery and the muscle building process. All right. Amino acid derived hormones. A great example of an amino acid derived hormone, like I said, is epinephrine. Although some of these hormones may pass through the cell membrane, epinephrine cannot, and it must bind to receptors on the outside of the cell membrane. So if it must bind to receptors on the outside of the cell membrane, that means it's having to bind to G proteins or specialized enzymes or even amino acids, right? So if it's derived from an amino acid, a lot of the entryway into the cell is it has to bind to an amino acid specific G protein in order for that amino acid derived hormone to take action on the target cell. So I know that was a lot, but just keep in mind that amino acid derived hormones, they were derived from an amino acid, of course, but that means that they will need some type of specialty receptor in order to take action on the target tissue. It cannot pass the cell membrane on its own like other hormones can. Okay. We also have protein hormones. They are not derived from amino acids specifically. They are derived from chains of amino acid or tertiary amino acids, meaning several amino acids put together. What are amino acids put together called? Proteins. And then that protein can be converted into a hormone. What is the primary protein hormone that we have? That is insulin, and these hormones are too large to pass through the plasma membrane. So once again, they need a specialized enzyme or receptor in order to take action on the target tissue. Okay, so let's talk about this process that I've been mentioning. Some hormones cannot pass through the cell membrane independently or on its own. There has to be some type of secondary messenger system, meaning the hormone is going to bind to some type of enzyme embedded into the cell membrane. And once that happens, then a secondary messenger process can take place. That binding of hormone to enzyme in the cell membrane initiated a process within the cell, and then it can have the target outcome. It can take its action. Okay. This whole process is receptors. There are specialized receptors for certain hormones. Okay. Water soluble hormones bind to the receptors on the outside of the cell, and this activates a secondary messenger system. What does a secondary messenger system mean? That simply means that the hormone couldn't enter into the cell. It had to bind to a receptor that initiated a process. Whoops. So here's what it looks like. Very important concept. The protein hormone, or the amino acid derived hormone, is on the extracellular environment. Okay. The second step is it binds to that hormone receptor complex. Okay. At the bottom of that hormone receptor complex is the G protein. Okay. That G protein relies on adenylate cyclase, which is an enzyme that initiates the action of the G protein. The combination of the two will then be that secondary messenger system. That G protein activation from adenylate cyclase will then yield some energy, but will initiate our cAMP pathway. Okay. And that cAMP pathway is responsible for too many intracellular things to count, usually heavily involved in protein synthesis. And if it's activating a protein synthesis pathway, then that means it's responsible for transcription and translation of RNA, That will then bind with ribosome, and then ribosome will produce amino acids. Amino acids will then exit the cell. Okay, so the secondary messenger pathway is usually activating cAMP, and cAMP is one of our big protein synthesis stimulatory pathways. Okay. All right. Now, steroid hormones actually do roughly the same thing. Steroid hormones, now they don't need a specialty receptor. Okay. They can enter into the cell membrane relatively easily. And steroid hormones, there's a number of things that have to happen, but let's take testosterone, for example. Testosterone enters into the cell. Okay, it's converted to 5-alpha reductase. I know that's not pictured in the slide, but that 5-alpha reductase is now going to bind to the nucleic membrane. Okay, and then that nucleic membrane, or that entry point into the nucleic membrane, that is going to initiate an intracellular receptor molecule that's going to be converted into a hormone receptor complex. And then once we have that hormone receptor complex, everything we see down here, we have DNA being spliced into messenger RNA. Then that messenger RNA is then going to go to the ribosome, and we've started that protein synthesis pathway. So the main thing that I want you to know between each slide is however the hormone got into the cell, either it needed activation of a G protein and an enzyme, or it entered into the cell on its own. In either case, most of the time, the conversion process is just trying to make its way to the nucleus so that we can stimulate protein synthesis. That's what's happening the majority of the time. Can other things happen? Sure. But that's typically the outcome of some of these protein hormones and these steroid hormones. We're trying to work our way to the nucleus of the cell. All right. So target tissues, once the hormone has gotten to the target cell, target tissues have a number of classifications. Okay, target tissues are defined by the location of the target tissue as relative to the delivery of the method of the hormone, right? So the classification of the target tissue is dependent on how the hormone is being produced. Okay, now if we have autocrine tissue, that means the cell is stimulating itself. That means the tissue needs a hormone. The tissue produces the hormone, produces it itself. Okay. Then we have paracrine tissues. Okay. That means nearby cells without entering the blood, right? So we're going to stimulate the tissue to the neighboring tissue, or the hormone is going to stimulate the neighboring tissue, right? Without actually entering the blood. We have some direct contact there. Okay. We have endocrine, which means that the hormone is actually entering into the blood now, and it needs to travel to the target tissue. And then we have pheromones, which is kind of an interesting classification, but pheromones are chemicals that ignite a response outside of the body in another individual. Okay, so these are usually, sex characteristics or something to that effect. There are some theories that you can actually smell or sense pheromones to a certain extent, but this is going to sound a little bit gross, but you can smell it. Why do dogs kind of sniff the bottom area of a person? That is where there's the highest concentration of pheromones. There's kind of a specific sexual function in that area. It's the most identifiable external characteristic of a person for a dog. So that's simply how they identify you. Now that's all a theory that pheromones can be actually sensed and smelled to some extent. But the point is that pheromones are produced and there is a response taking place outside of the body that another individual can observe to some extent, right? But we have autocrine, paracrine, endocrine, and pheromone, and these are all classifications of target tissues, and it just depends on how does the hormone get from one cell to another, okay? Autocrine, we're producing it within itself. Paracrine, it's taking action on the neighboring tissue. Endocrine, the hormone had to enter into the blood and travel to a target tissue. And pheromone means that it's actually traveled outside of the body to some extent. Okay. All right. So now let's talk about regulation of hormones. Regulation of hormones can take a negative feedback loop or it can take a positive feedback loop. Regulation of hormones happen on a moment-to-moment basis, and there's 3 modes that take place. Neural stimulation of a gland. Okay. That's either going to produce, we need to stop producing this hormone or we need to produce more of this hormone. Okay. One of the two. Okay. Another hormone is stimulating a gland. Okay. Hormone, thyroid releasing hormone, then stimulated a gland to produce thyroid stimulating hormone. That's an example of another method. Okay. And then a substance other than hormones stimulating a gland, right? So it doesn't always have to be a hormone, right? So one of 3 things are taking place, and this is regulating the distribution on a moment-to-moment basis. Okay. Like I said, one method of hormone regulation could be a negative feedback loop. A negative feedback loop, again, means that something is taking place and then a counteractive effect takes place in order to bring it back down. So, for example, if we produce too much or if we produce enough of a hormone, we have to have some type of process that brings that hormone production back down. So a negative feedback loop means that something went up and then something was produced in order to negate that or to bring it back down. And then we have that negative feedback, right? So negative feedback, a hormone is secreted when the concentration of a substance is too low or too high. We need to bring it back to homeostasis. The hormone causes body cells to bring the substance level back to normal. And once normal levels are reached, hormone secretion and concentration decreases. So just remember that if the hormone is too high, too low, or we just simply don't need it anymore, negative feedback is bringing it back to homeostasis. Something was negating that hormone production. Okay, regulation, protein, All right, transport action. Okay, we already talked about that. Tissue, binding receptors. Okay, and now let's talk about a process of, before we get into a positive feedback loop, let's quickly talk about upregulation of a hormone versus downregulation of a hormone. Okay, upregulation of a hormone, both upregulation and downregulation are referring to the number of receptors for a given hormone. So, for example, a hormone is only as effective as it has the necessary amount of receptors. Okay, we may have a lot of a particular hormone, but if we don't have the corresponding amount of receptors, then the hormone can't take action. Right? So if we upregulate a hormone, that means there's genesis of more receptors, so more of the hormone can take action. We increase the receptor density. How does upregulation of a hormone take place? It usually means that the hormone is chronically elevated for whatever reason, so therefore the body compensates by producing more of the receptor. So for example, if I have chronically elevated testosterone for whatever reason, over time my testosterone receptor density is going to go up to try to upregulate and meet the demand for the amount of circulating testosterone. The exact opposite can happen in terms of downregulation. We can downregulate receptor density. If there's chronically low amounts of testosterone, then receptors are either not produced, or the density does not go up, or receptors are downregulated, right? So that means there is a reduced amount of receptors because the testosterone level was chronically low. Okay, so in any case, upregulation versus downregulation, it is a process that happens in direct response to the amount of circulating hormone over time. Okay, so just keep that in mind. Hormones only take action if they have the necessary amount of receptors. Okay, so these pictures are very helpful. as there is elevated amounts of a hormone, the receptor density goes up in response to that. That's an up regulatory process. And then the exact opposite, if we have too little of a hormone or suppressed hormone function, then the receptor density goes down over time, and that's a down regulation process. Okay. All right. A couple more things that you need to be familiar with. Hormone elimination is another regulatory process. Hormones can be excreted. Hormones can be metabolized. They can be actively transported, or they can be conjugated. Okay. What does excretion mean? That means the kidneys have removed the hormone. Simple enough. Metabolism of a hormone means that there was a corresponding enzyme for the hormone. Okay. Active transport means that it was recirculated, and conjugation simply means that if it's a water-soluble hormone, then that means the liver is going to combine it with the water, okay, and then it'll be excreted eventually. Okay. All right. And hormone elimination is also directly in relation to the half-life. If you don't know what a half-life is, here's what it is. Half-life is the amount of time it takes for half of the substance to be eliminated. Okay. So if something has, a 5-hour half-life, that means that it took 5 hours for half of the substance to be eliminated, right? And typically it takes about 6 half-lives in order for it to be completely eliminated. So if something has a 5-hour half-life, 5 times 6, that means it took 30 hours for the substance to be completely removed. Okay. So keep in mind that excretion of a hormone, the rate at which it's excreted is directly dependent on the half-life. All right. So there are some case studies and some scenarios that I want you to work through on your own time. I'm not going to go through all 4, but scenario number 1 is referring to insulin and glucagon secretion. Okay. First one, hormones such as insulin and glucagon are used to maintain homeostasis. Homeostasis of what? Blood sugar. Insulin and glucagon, that is an example of a negative feedback scenario, meaning that if blood sugar is too high, insulin is going to be produced in order to bring the blood sugar back down by removing the sugar from the bloodstream. If blood sugar is too low, then glucagon is going to be produced in order to extract sugar from the cell and put it back into the bloodstream. So we're going up and down and up and down. That's an example of a negative feedback loop. We had too much or too little of something. A process was initiated in order to bring it back to homeostasis. I want you to be able to take a combination of hormones and be able to state, is it negative feedback or is it positive feedback? All right. Oxytocin, a couple more concepts. Oxytocin is one of our best examples of a positive feedback loop, meaning that we produce a certain amount and that hormone is going to stimulate more production of it, and then more production of it, and then more production of it. And we're constantly driving it further and further away from homeostasis until there is a certain outcome. So childbirth the childbirth process relies on oxytocin, because oxytocin is going to stimulate the release of more oxytocin, and then more and more and more and more until the cervix is dilated enough for childbirth to take place. So just keep in mind that the childbirth process is one of our key endocrine examples of a positive feedback loop. Okay. And effects of aging on the endocrine system. Typically, we start to produce less and less of certain hormones as we age, particularly steroid hormones, testosterone, progesterone, estrogen. All of these things typically go down. And this is primarily due to down regulation of receptors over time. Now, of course, if we stay active and healthy, then this down regulatory process is diminished to an extent. But that is one of the main actions of aging. How do we diagnose endocrine system dysfunction? Okay, we do so typically through blood tests. We take a blood sample to see how much of the hormone is currently in the blood. If it is a hormone that is not produced in transferred through the bloodstream, then of course a blood test is not going to do us any good. Then we can use computed tomography or a CT scan, or we can even do a DEXA scan to see, the amount of hormone at different components of the body. But in any case, we have to know how much hormone is in a particular area, and then we can render a diagnosis. We could do an MRI, we can do a urine analysis, see how much of the hormone is in your blood, and then, of course, an X-ray as well. Okay. All right. One of the key endocrine system disorders that I want you to be familiar with is diabetes. Okay. Diabetes can be type 1 or type 2. Type 1 is genetic, meaning that you do not produce insulin at all. Type 2 is typically a lifestyle factor, meaning that you have developed insulin insensitivity over time. And in both cases, blood sugar is not being managed correctly. Okay. Symptoms of diabetes for both types is excessive thirst, polydipsia, okay, excessive urination, polyuria, and there's glucose in the urine, meaning glucose urea. Okay, so those are the three main symptoms of diabetes that I want you to be familiar with: excessive thirst, excessive urination, and sugar in the urine. And in all cases, if you have uncontrolled diabetes and uncontrolled blood sugar, that can be life-threatening. Okay, here's an example of a glucometer. You can get it anywhere at any pharmacy, right? You prick the finger, and then the glucometer and the test strip will determine the amount of glucose that's in the blood, and then you can get a reading. Excuse me. All right, diabetes insipidus, okay? Diabetes insipidus is a problem of insufficient ADH secretion from the posterior pituitary gland. This results in the same thing. Just know the symptoms of diabetes insipidus. The causality is a little bit different. If you have insufficient amounts of ADH hormone, then of course that's going to result in a different form of diabetes insipidus, but it manifests the exact same way: excessive thirst and excessive urination. Okay. And I do want you to be familiar with a few growth disorders that are directly associated with endocrine system dysfunction: gigantism, acromegaly, and pituitary dwarfism. All of these things have the same causality, and that is too much growth hormone is being produced or not enough growth hormone is being produced. Okay, here's an example of dwarfism: not enough growth hormone, and it results in stunted growth. Or acromegaly, which means abnormal growth of certain portions of the body: the jaw, the skull, really everything. And acromegaly, of course, can be life-threatening. That results in uncontrolled growth of bone, which of course can result in organ failure. Okay. And then finally, there is goiters. Okay. Goiters can happen from hyposecretion or hypersecretion of thyroid hormone, like we talked about. If you're iodine deficient, then that can result in problems with thyroid hormone functioning. Goiters are, swelling of the thyroid gland, and it looks like this right here in the picture. This is an endemic goiter. Okay, and just remember that goiters are typically associated with Graves' disease, right? And it's dysfunction of the thyroid hormone or thyroid gland. Okay, there's hyperthyroidism and there's hypothyroidism. Hyper, too much thyroid hormone. Hypo is not enough thyroid hormone. Okay, hyperthyroid hormone is called Graves' disease, and hypothyroidism is called Hashimoto's. Okay, and then finally, let's talk about Cushing's syndrome. Okay, Cushing's syndrome is a collection of disorders within the endocrine system. Okay, and it's due to the hypersecretion of adrenocorticotropic hormone, okay, from the pituitary gland, and this has resulted in tumors within the pituitary gland. Okay, too much is being produced, tumors have developed, and it results in significant abnormalities, uncontrolled growth of adipose tissue, right? And the adipose tissue can, manifest in a number of places: abdomen, face, even the eyelids, it looks like, right? That's an example of Cushing's syndrome. Okay, I know that was a lengthy lecture, but if you have any questions, feel free to email me.